We all go into medicine or surgery for different reasons, and I think the best part about doing orthopedic surgery and arthroplasty in particular is that you typically take people from a fairly limited standpoint from mobility to back to where they can function and do things that they did prior. This is different obviously in revision situations. However, you can significantly change and impact someone's life. Whether their goal was to simply walk around the block with their partner or be able to sit in a car and go on trips with their family, it varies from patient to patient. So going through this process with them and obviously we have many discussions, sometimes multiple follow-ups prior to even undergoing such a procedure. So we get to know these patients quite well, and I do think that they really appreciate the effort and time that we put in to try to give them the best possible outcome we can get them. Essentially, when someone suffers from end-stage osteoarthritis, whether it be the hip or the knee, and have exacerbated all conservative managements, which can include physical therapy, exercise modification, weight loss, injections, etc., they end up in our office for consideration of a total joint. On the hip side, what that consists of is mainly two metal components. One that replaces the cup side of the hip, which is on the pelvis, and the other side which replaces the femoral head and neck. So it's a stem that we put in the femur. Those two implants can be either cemented or uncemented, and also a plastic component which articulates with the ball of the total hip component. For a total knee, similar concepts. Obviously the surfaces of the joint which have been infected by the disease get removed, and a tibial component, which sits on the shin bone, gets implanted along with another component on the distal aspect of the femur or the thigh bone, and then a plastic component in between the two, which allows the joint to articulate smoothly and hopefully allow the patient to regain their motion and function afterwards. Revision hip and knee surgery can be for many reasons. People get loosening around their implants on occasion. They can dislocate, so particularly in the hip, people get what we call instability for a variety of reasons. Infection is a big one. We always talk about our patients about infection preoperatively. However, many factors come into play, both surgical and patient factors. And so when these instances occur, we obviously assess the patient once they present to either our clinic or through the emergency. We perform the appropriate tests, whether it be imaging testing, lab testing, or just a general physical exam. And based on those things, we can make the appropriate diagnosis. And if this is a component that needs to be revised, either partially or completely, meaning taken completely out and replaced, then we do that. And the people who typically present with these issues are severely affected by it. It affects their day-to-day life, it affects their motion, their ability to do things that we take for granted, and if done appropriately, it can significantly impact the rest of their life moving forward. This is something that sometimes requires full removal of the implant and a surgery that is performed in a staged fashion, meaning that, for example, in an infection setting, if depending on what type of bacteria we're dealing with, what type of patient we're dealing with, this may require us to implant a temporary implant which is typically used to deliver a high dose of antibiotics in the area, along with collaboration with our infectious disease colleagues to suppress the infection. And then once the infection is under control, we can then proceed to re-implant a new revision component that we hope lasts the rest of their life. Depending on the age of the patient and obviously the complexity of the case, that can change. However, that is the ultimate goal, is to eradicate the infection and allow people to kind of return to regular life. I think it is due to the general increase in procedures that we're seeing now with the baby boomer generation coming to an age where their joints may be an issue and they're undergoing either total hip or total knee replacement. Because of the general number increasing, so are the number of revisions. Based on the data that we do have now, it is a drastic and an exponential increase. It is not gradual at all. I think us as arthroplasty surgeons in the area have to be aware of that and be ready for that, and so do the hospitals, because it is something that we cannot avoid. I think if you set good protocols and follow standard of care, you'll be able to help a lot of these individuals. However, yes, it will be a significant hurdle for many who are in this field. When we do these surgeries, we go through a very thorough discussion with the patient, and I think setting patient expectations from day one when we meet them in the clinic or whether we meet them in the ER is super important. So, is this a life-changing event when someone has an issue requiring revision? Absolutely. Will their knee or hip function be what it was prior? Most likely not. It will be different. From a soft tissue standpoint, from a bony standpoint, from the implant that goes in, and its freedom of range of motion, all those things change. So I think that if you have a thorough discussion with the patient and they understand that, then yeah, it'll be significantly impactful to them, because the potential worst complication is that you cannot eradicate the infection. This infection spreads and it becomes a systemic issue. Further bone loss or further muscle loss occurs because of neglect or other. And so when those circumstances happen, in rare circumstances, amputations may be required, and that's the loss of a limb. And so that is even more life-changing. However, going through these revision surgeries is also very burdensome to the patient, because, as I mentioned, sometimes it requires multiple surgeries. So these are discussions that we have with the patient, and based on what their requests are, we can sometimes modify our treatment course to maybe control things and not completely eradicate, or maybe suppress the bacteria in an infection scenario to give them comfort, but the goals of care become different in those circumstances. In an academic institution, a lot of us, come to these centers to deal with these specific types of cases. So, everyone has their own respective motivations to take on these cases. For me personally, I think it's a population that obviously is suffering and needs help. And yes, as you mentioned, oftentimes gets ignored. And this could be because it may be a private center that doesn't have the resources in terms of anesthesia or beds. It could be a financial reason. It could be a location reason, meaning the patient is not in proximity to the institution that does these procedures. So there's many factors that come into play. But us being an academic institution, I feel that we should have the highest standard of any institution that performs, hip and knee arthroplasty or revision arthroplasty. And so in order to maintain a standard and to maintain a high quality of surgery, you have to do them, and you have to do them fairly frequently. So we're here to help, and of course we enjoy doing primary hip and knee surgeries, but some of these people, a percentage, will have issues, and we're here to help.